The live lab simulation exercise was a really exciting opportunity to give undergraduate nursing students in their second and third year of the program an opportunity to really have some additional clinical experience and exposure to real patients. At the moment, it's only 800 hours of clinical practice that an undergraduate student gets, and they always say, I wish I just had more time to practice the skills. There were three main objectives for this live lab simulation. The first one was to allow second year students the opportunity to practice skills with live patients. The second objective was really around the third years, and there were two parts to this. The third years never really get a time to practice to be a preceptor, to be a mentor. So we actually said to the third year final students that you're actually going to be a registered nurse. All the responsibilities of a registered nurse, and you're going to have a student with you. So they practiced the preceptor and mentor skills that they needed, and also it was around prioritising time and a transition to practice.
Doctor wanted a clear dressing down.
Yep. So tegaderms are over there. But even though you're putting a clear dressing over it, it's a hole, so you'd still need to put some gauze over the top for pressure.
So you want an off-site?
So you'll still use a clear dressing, but you'll need a small, I'd use the gauze out of the dressing pack.
Okay.
And fold it up small to provide a bit of pressure.
And the final objective was around allowing academics and educators the opportunity to be a part of a very large simulation in a very active learning environment. This was actually a very ambitious project, and it actually is quite complex. You probably don't see, and students wouldn't see, all the work behind the scenes that actually went into creating this live lab experience for them. To start with, we got together a group of clinicians and academics who worked on the actual running sheet or the plan of the day. We then had to work out a location, actually modify those labs, and created 3 clinical spaces that looked as much like a ward as we could possibly get it. And so when we're actually allocating patients to different sections, I didn't want to put all of the very high acuity patients into one section, nor did I want to put all the very low acuity in another. The students would very much pick up on that very quickly, and they would then anticipate. And I didn't want any anticipation of what might actually occur. So in fact, our highest acuity patient or fidelity patient had an arrest. She was ready for discharge home, and so she was ignored most of the day until she actually became short of breath and arrested on the students. So it was very deliberately planned where each patient would be located. We actually, in this particular incident, wanted to have some paediatric patients. We also wanted to have some run-of-the-mill, very common presentations to medical surgical wards, so a mixture of medical surgical cases. Then moving up to things that were a little bit more high acuity. So we managed the cases and very strategically placed them in the 3 areas. We then had to think, well, how can we support the students to do that? So in each of the areas, installed a unit manager. So this is an academic clinician, very experienced person who was in charge of the 4 patients in that particular area. We then had to have auxiliary crew, a catering staff, because if you've got live patients in a hospital, they have lunch. The other thing that was important was, how are we going to record this? So there was a film crew. We had 2 roving cameras, and above each of the beds was a static video recording device. Behind each one of the patients is a full script and a backstory. The other thing, I went looking for actual actors with conditions, and so the majority of our patient actors actually had their own conditions, and we actually wrote the story or the script around their conditions. So students really saw that what they were dealing with was real patients with real stories, real history. So when I use the term script, I use it very loosely. The script really was around the backstory and what I hoped might actually occur. So we mapped out the 4-hour simulation experience thinking what might happen if the student did this, this might happen. If the student did that, then this might happen. However, for all the scripting in the world, this simulation was really about the student's interaction with the patient, and they had to flow with whatever was going to happen with that patient, and therefore the patient then had to stay very much in character and not come out of character for the entire duration of the lab. And that was the important part, and that really helped with the realism as well.
How are you going, Sabrina?
Oh, a bit better now. I've had a smoke finally.
Oh, excellent. Well, how about we sit you back down into your bed? And...
No, I just want to sleep now.
Okay, all right.
So we added an extra dimension to what we were doing and how we were running the lab by actually inviting a couple of the patients to bring relatives with them. Now, these were actual relatives. Well, that brought such depth to the interactions that the students had with the patients. The students' experience in the live lab simulation began as they entered into the university. They were directed to a debriefing room, and then they were given a clinical handover by the nurse unit manager. During the clinical handover, all the students were provided with a handover of all the patients in the whole ward. So not just the area that they're going to, but the entire ward, so that if anything happened or that they were team nursing and had to go to other patients, that they would know the scenarios behind.
Right side, lower, so it's, yeah, nice dry, just needs to monitor for that as well.
Yep. Any dressing changes due this afternoon?
Not this afternoon, but the doctor will come and review.
No
Yes, so we might just have to keep prompting the doctor for that.
So how old were you? You said you just come out of...
He's just coming out, so I'll probably do 15-minute obs on Isaac.
There were 2 groups divided into 2-hour lots, 2-hour shifts, very similar to what you do in a clinical laboratory. So as they then were taken down into the ward, they were introduced to their patients. And like most shift, you go in, meet the patient, have a look at the notes and start prioritising your care. So the scenario had already started by the time they came into it, so it was a bustling, busy ward that they entered.
This is Nick. Hi, Nick. There's a nurse, Alyssa and Nick are going to be looking after you. So Nick has got a spontaneous pneumothorax, and Erin, is there Erin?
Yeah.
She's reviewing.
Yeah,
okay.
So he's got quite significant decreased air entry on that right-hand side. So, and I've had a look at his x-ray, he's got quite a decent pneumothorax on that right side. Can I get you guys to set up for a chest tube for me and underwater seal drainage to get ready to insert? I've just got to go review a couple of other patients. So if I leave you guys to do that and I'll come back and...
There were 2 paediatric patients. One was a young 11-year-old who'd fallen off a bike, who had a fractured arm, had already been to theatre. And his injuries, though, were greater than what you could see. And he had some unusual bruising on his flank at the back on his back that needed to be investigated. The second paediatric patient was a 13-year-old who had acute abdominal pain and was being prepared to go off to have an appendicectomy. So during the scenario, he went off and had his appendix out and came back post-operatively. We also had a chest infection that was a pneumonia being treated with IV antibiotics. There was a lady who had a thyroid removed, who had a drain tube that was removed during the scenario. She didn't get a very good prognosis, and so she was informed that in fact the lump that they'd removed from her thyroid was actually cancerous and that she'd need to deal with the next section of her care, which was heading to an oncologist.
So it does look like those cells that they've taken from your biopsy are cancerous. Okay, they were malignant. Okay. So at this stage, it's a very similar plan to what I mentioned before about the iodine, taking the radioactive iodine and getting rid of all of the cells from your thyroid. But I'll need to speak to the oncology department about what your treatment needs to be from there on.
We had a patient who had COPD, who actually has home oxygen for real, and that was written into the scenario. And he's always in and out of hospital in his actual life. During the scenario, for him it was about really talking to him about what end-of-life care is all about, and that, you know, what does he want to have done if something is to happen, if he arrests, if he becomes sicker than what he is. With that particular scenario, he had his wife there, so that was really deep and meaningful conversations that they had there around end-of-life care.
Your lung cancer that we've been looking at has obviously gotten a far lot worse since we saw you last. And your last lot of tests sort of showed that it was heading into your lymph glands.
Not good.
No, and in other areas. So we're not really sure there'll be much more that we can sort of do to treat it as far as chemotherapy or radiotherapy goes. And you're probably too unwell, I think, to have any sort of surgery to take away. No, that's not very good at all. So I think where we're at now is sort of having a think about what you would like us thinking about your end of life and things that you would like to have as part of, pain relief and, keeping the best of your quality of life.
We had a gentleman who had chest pain, and the chest pain was ongoing, and so the students really need to manage that chest pain and get on top of it with anginine, with morphine, with oxygen therapy, checking his oxygen saturations regularly. But he has a backstory, because this gentleman with chest pain also had renal failure and had a kidney transplant and has a live fistula. Well, we often you'll hear nurses say, yep, the blowflies are moving. So blowflies,
yes.
it's like a bunch of blowflies in the vein that are just making. You did, and it's just buzzing in there, isn't it? Because it's got that bit of buzz to it.
Yeah, and it's such a good fistula, I never used it.
It is, yeah, that's right. And well, he's lucky you did.
I'm glad. I'm so happy for him.
Yes. Good, no, definitely, that's right. So he had a complicated backstory as well as presenting issues that the students needed to deal with.
Is it easy? You haven't got a headache or anything?
Just a faint headache now.
Faint headache?
Sort of fading away a bit.
All right. Are you warm enough?
Yeah, I'm very warm.
Okay.
We had a couple of other lower acuity patients. We had a farm accident, so a farmer who'd come off a quad bike and had a fractured femur, full leg plaster, and another patient who'd had a transresection of his prostate, so prostate removed, and he actually had a bladder washout occurring. And the bladder washout in the urinary catheter was very blood stained, so students needed to manage that urine output and to be checking it, checking his vital signs and checking for extra blood loss.
I think we can run it through at a slower pace at what it is, but we can, just as long as we're seeing that urine doesn't get any more concentrated. So it might be worth, just for this bag, run it through, because we haven't got much of a bag yet. Let it open for that. Once we go into the new bag, we'll see how clear the urine comes.
Okay,
so
great.
We'll do it that way.
Thanks, Coach.
There was an interesting psych patient who was a Panadol overdose who came through the emergency department and was admitted to the ward. And she'd had charcoal in the emergency department, so she actually had a little bit of charcoal around her mouth. And she was in and out of drowsiness and up and down with her emotional state, as well as becoming slightly aggressive. She was a smoker and needed to go out for a cigarette as well. So the students had to manage her and her needs throughout the simulation.
Sabrina?
What?
Sabrina, hi, it's Alyssa here.
Hi, what do you want?
I'm just wanting to come in and say how you are. Can you tell me a bit about how you're feeling?
Can you just get Wayne? I really need you to get Wayne.
Yeah, can you tell me a bit more about Wayne? Oh, it's just that I'm just new to the shift at the moment.
No, I need him to come.
Yeah.
He's gone and left me. I need him.
Okay. All right, well, I'll see what we can do.
I've never had that horrible back stuff before ever. I don't want it.
Do you ever have any voices in your head?
Sorry?
Do you ever have any voices in your head? Anyone talking to you?
No.
That you can't see?
No, I'm not a nutter.
I wasn't implying that, but sometimes when we get really depressed and down, sometimes we do hear voices. She's still a bit irritable, which is understandable. She wants to have a sleep now, but I've explained to her that, we're going to have to follow up with the doctor and I'll need to see her again before we possibly consider discharge. What's interesting about Sabrina is that it was an impulsive suicide. She didn't actually want to kill herself, but it was more of an attention-seeking for Wayne to actually come back and discuss the issues. So an unintentional overdose as such. She still needs to be monitored and we'll still need to keep an eye on her GSE.
There was a young female that was very quiet throughout the scenario, and this particular patient had had a spontaneous abortion. You know, she was trying so hard to have a baby, and this particular patient actor brought so much emotion and distress and loss of hope to her character that students were very reluctant to really engage with her. But in fact, she was just so sad throughout the entire simulation. But when we spoke about it in the debrief session, she was very insightful about the particular students that had come up and just touched her hand or just given her some words of encouragement. We also had a chest infection that was a pneumonia being treated with IV antibiotics. Many of our educators volunteered to be patients, and one such was a gentleman who actually is insulin-dependent diabetic. So he was great because he had such insightfulness into his own condition, and as the students were managing his blood sugar levels and actually on a sliding scale of insulin, he brought such realism to his condition.
Let's do this dressing.
Okay. It's yeah, it's down up here. It's a bit yuck.
And you know, diabetic fellas, if you don't look after your feet.
Yeah, the nurse this morning said a little bit about that it can be, it can get really bad, or my blood sugars can not help the wound much. Looks like pus to me. It's gross.
We had a 20-year-old patient who had a spontaneous pneumothorax. He is a smoker and very, very skinny fella, so you've got that elongated lungs, and it was just a spontaneous pneumothorax. He'd come up through the emergency department. By the time he'd hit the ward, the surgical consultant had said he needs a chest tube and it's all ready to go. So the students hit the ward running with this particular patient. Again, it was about prioritising across their patient load, knowing that this particular young fella needed a chest tube put in as soon as possible.
It's going to be a bit sore. Just take your breath in for me. Okay. Suture that in.
Yep.
Put it underneath there for you. Or do you want me to open?
Can I get you to open that one up?
Yeah, sure.
Okay, ready to connect? Turn onto the suction. It needs to be connected to the suction. Yep. Should do that. Try and do it, or just tape it into position.
We really wanted to run an arrest. The scenario was written around a lady who'd had a knee operation, and she was actually getting ready to be discharged home. Her son was there visiting, and all during the shift, she just felt a bit short of breath and a bit not quite right.
But it was sore before the operation, and I thought once they put the new knee in, it would take the pain away, and it hasn't.
Okay. How would you rate it out of 10 now?
Oh, 5.
A 5? Yep.
Yeah.
Okay.
Yeah.
So it hasn't increased at all?
No, I think it's just as sore as it's always been.
Yeah. Do you think that maybe if you got out of bed it might ease it a little bit?
I don't know.
You don't know? Do you want to maybe give it a try?
We could try.
Yeah, let me just have a look at your notes.
Yeah.
Because I know that the physio does want to get you out of bed, so the quicker we get that done, hopefully the better.
So when finally the son calls out and says, help, help, you know, mum's not well, it really caught the students off guard. It wasn't the patient scenario that they were expecting.
She's just stopped breathing.
Alright, I'll get you to step back. One second.
But Mum.
What's mum's name?
Lynn.
Lynn? Lynn, can you hear me? Can I get some help in here, please? Lynn? Lynn?
Mum.
Alright. Okay, this is your patient group. I'm just going to remove the cover. Okay. What do you need me? You've got it covered? We'll just depending. We'll just check your airways and then we might get a crash cart if that's alright. Yeah.
What's going on, guys? What's happening?
Lynn's unresponsive at this point, just putting her airways.
I'll call code.
Call code. Let's. Yeah.
What's going on?
What's happening? What's been happening before that?
Just a minor change. She's in for a total right knee replacement.
Okay, so she got airway.
No.
All right, I need someone to go get the crash trolley. It's around
All
here.
right. Jason, can you just
No
start with me?
Yes.
Yep. And resus trolley.
We need to get resus. Yeah. Someone note the time, please. We need a crash trolley. Can someone be scribe? Linda, can you get a piece of paper?
Okay.
Tell me what's been going on. Hand over.
Okay.
What's going on?
We've got the trolley hand over to the doctor.
Thank you.
Grab the air
Please be scribe with me.
The doctor's on at the end.
This.
Can you hand over to Sarah?
Lynn's been in for a total right knee replacement.
All right.
Kind of red
So, the time is
she had
2:03.
Can we check her IV access, please?
Erin, do you want adrenaline?
Yes, please.
A milligram of adrenaline, please. We can.
They were supported by all of the clinicians who came in and took the leadership roles in the arrest. However, it gave the opportunity for the students to be a part of different aspects and roles within the arrest scenario.
Can you go around and help with airway?
Yep. Oh, sorry, that was me.
Begin by removing all clothing from the
Need to give you
patient's
adrenaline. Give her adrenaline. Give her a flush afterwards.
Yep, flush pre-post.
Now
I'm going to work around.
the yellow plastic pipe.
So we just.
My mother.
Look carefully at the pictures on the white adhesive pad.
To add another dimension to what we were doing, you had the sun. Now, that is one thing within an undergraduate degree that we don't do enough of. We don't teach students enough of how to have those difficult conversations to support family members when it's an acute episode, and definitely not when it's a resuscitation. So it was something we really wanted to touch on, and then again touch on in the debrief session so that they could learn from this scenario.
Okay, systole.
Still asystole. All right, continue CPR. Okay, so she's hospitalised. Large flush. Good. Okay, let's see if that helps.
Okay. Okay, we've got third adrenaline ready.
Yep, that'd be great.
Can we have a time check, please?
It's been 6 minutes since it collapsed.
Why has she woken up?
Do you want to come sit down over here?
So third dose of adrenaline, retiplase has gone in, compressions,
Yeah.
asystole.
Yep.
We've got a secure airway.
Yep. So we've got size 7.
We're doing everything we can. We've got the best
All right, rhythm check.
working on the situation.
Why doesn't she just wake up?
Yep. Okay, CPR.
210 was our third dose of adrenaline.
She's just having a bit of
And
a
our
rest.
retiplase was given 208.
To get her back.
Great.
But you did a good
Retiplase,
job.
great.
You got straight away. So time is everything. Everyone was there. That you did the best job you could.
Yeah, we'll get ready for a fourth dose of adrenaline. Fourth.
Someone getting the history. We know what the history is. I'm just trying to think of any other things, reversible causes. The last path I think was going okay. Yeah, electrolytes were all right in the last path.
Yeah, that'd be great. DVT that's moved up.
PE maybe?
Into the PE.
DVT, PE,
Yeah, that's what I'm
maybe?
thinking. So we've given her thrombolysis.
Okay, we're ready for another adrenaline if you want it.
Okay.
We'll do a rhythm check first.
Yeah, let's do a rhythm check.
Stop, rhythm check. Asystole.
Okay. All right. So continue CPR.
Fourth dose of adrenaline.
Yeah, might make this nice first. So, what was your name? Was it
Colin.
Colin. My name's Erin. I'm one of the doctors on today. So is this your
Mother.
mum?
Yeah.
So
She had an operation yesterday for a knee reconstruction.
yeah. Okay.
Supposed to be up walking around today.
Yeah, that's the plan. I saw her earlier.
What's happened?
Yeah. So it looks like her heart stopped for some reason, and we've just tried all the things that we can to try and get her heart started. So we've just given her lots of adrenaline, and we've also given her some medication to help dissolve any clots that might be the problem. But at this point, we're not really getting any heart rhythm back at all, and certainly no response. So I'm not really sure that there's much else that we can do to try and bring her back, unfortunately. So if we're all in agreement, I think we can probably call it at the moment, if that's okay. Yeah, there's not much we can do. All right. So, any objections otherwise?
No.
I think we've sort of done all we can. I don't know what else we can sort of do.
No.
Yeah.
4 rounds of adrenaline, CPR,
okay.
Ventolin, being intubated,
Yeah.
plays.
All right, so I might call stop for the CPR.
Okay. 14, 13.
So plan should probably be a coroner's case, given the nature of the unexpectedness of her collapse, and the fact that she's also had surgery recently as well. So what we'll do is we'll keep all the lines and drips and things in place, because they will want to have a look properly and do an autopsy to see what the actual cause of these things. Unfortunately, we couldn't really get any rhythm back, and so there was no heart beating and no output. Certainly no blood going to her brain and her organs, even with all that adrenaline we're trying to get out of her. Okay. Yeah. So I'm very sorry.
Unfortunately, make sure that we've got our specifics that we would
She was coming.
Yeah. Alright, so I just need to write up that adrenaline.
All students and all participants of the live lab were then asked to stay around, because at the last thing of the day was that we had a final debrief session. We were now able to hear from everyone, and everyone giving each other feedback.
Excellent as a 30 student, because we're where we want them to be. But what Luke did, he had Nick under pressure with Nick, but what he did was delegate. And he said to me, can you please do this? Alyssa, can you please do this? And for him to do that and not get flustered and go, I need to do everything, oh my God, I've got an unstable patient. That's why Luke that was very good, Luke. It was really, really good. So well done for that.
At that particular point, we also were able to highlight some of the little tiny things that perhaps the students may not have picked up on. For example, the paediatric patient who'd fallen off his bike had been to theatre and had a plaster put on, but in fact had a very large bruise to his flank region on the back. And none of the students involved in the scenario had actually examined this child, and he was a happy kid, but he had some unusual bruising that should have been investigated. And one of the students then commented, yeah, I'll never forget that. I'll never not do a thorough examination ever again. And they actually learnt that they can't just rely on the notes, that they can't rely on the handover that they're given, that their own abilities of critical analysis, critical thinking, and also around being very vigilant with their health assessment and really looking at the notes and really looking at the patient makes the difference. It was really interesting to hear the perspectives of the students of what they've taken away from a live lab simulation exercise. For many of them, it was actually really brave to come on board this project, knowing full well that they're going to be videotaped the entire time, and that really put a lot of students off. The students that did participate, however, the feedback from them has just been extraordinary. There is the learning of skills, the practicing of the hands-on, actual clinical skills.
In what way have you benefited?
Awareness of the things I need to improve on.
Yeah.
Definitely one.
Yeah. Strengthening the knowledge that we already know and have learnt.
Because you actually do know stuff.
Yeah. Something awesome. Thank God.
Actually being able to perform skills, but also on real people, but also having the ability to get feedback and check on things.
So I want to ask about that. What was it like to go into the labs that you're used to seeing mannequins in the bed, to walking into a full hospital with real patients in the bed?
Yeah, it was really great. It was good. It was really good. I had amazing patients.
You'd like to do this each week?
Yes.
On top of that, there was the non-clinical skills that they learnt as well. it's really hard to teach communication skills, and this was a huge opportunity to really, in a very safe way, in a safe environment, to learn to really communicate and have difficult conversations with patients and with their relatives.
And so on, but like the realisation that it can kill you, and then that rippling effect, well, you can't just do that, present and go home. We've got to check this, we've got to make sure there's all these services in place, and if anybody had to come back into the room once more, I tell you, I was going to pull up the bum. I thought I made it quite clear I did not want to talk to her. Eventually, when I settled down, I did, and then her words of wisdom were wonderful. But then, in the interim period, it was like I was being judged by my lovely nurse, you know, asking me how much do I drink, and it was like, oh, so now you think I'm an alcoholic. And then promised me I could smoke, and then they wouldn't let me go for a smoke, and I was quite difficult to handle, but they handled me very,
And I will
very
say all of the students actually requested to go back into the live lab simulation, to do it all again. What lessons had they learnt? What would I do differently coming in next time? I wish I could offer them that opportunity again, because I think the learning environment was fabulous.